Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back, listener, to another episode of the Rural American Surgeon. I am honored today to have a guest. He was sent to me as a guest from Dr. Gary Timmerman you got to talk to this guy, basically. And it sounds like you're from the same town and you're going to have some great stories to share about a practice in rural South Dakota. So thanks so much, Dr. Gerrish, for coming on my show.
Yeah, my pleasure. It's exciting.
Yeah. So, and you started practice in 2016, and I'd just like for you to give your own introduction about your training, background, what drew you to where you are, and what your practice looks like.
Okay. I'll go way back. So, this is kind of interesting, but my grandfather was a general surgeon, but he trained at like Case Western in Cleveland. And I think he eventually got burnt out of that and moved to a small town in Minnesota, and it eventually landed in this small town in mid-South Dakota called Mobridge. And that's where my dad was born. Or he was born in Cleveland, but he grew up in Mobridge. Mm-hmm. And then he later moved back to Chicago to be like higher up in the College of Surgeons. So that's where he finished his career. But my dad loved hunting and fishing. He loved South Dakota more than moving back to Chicago. So he became a general surgeon, and he moved back and started his career in Watertown as well. So he started in the early 80s. He's since retired, but that's where I got my background and exposure to surgery, because those were the days where you could bring your kid to work day almost any day. So some of my early experiences in the OR were going to work with Dad, and I can remember just their basic appies and like gallbladders, but I can remember some nasty bowel obstructions and stuff like that. So it's imprinted early.
At that time, were you able to go actually into the operating room then?
Yeah. And I mean, they kept it pretty safe. I might scrub and just have my hands on the table like, a young student would, but.
Yeah, this would be like what age were you?
I would bet 12. I started. Yeah.
Wow.
So.
Yeah. Well, I mean, I did some of that in my own independent practice with my kids. Because I had my own office. And so that's minor surgical procedures, but of course not scrubbed in, because they were like, at that time, the oldest one was 7, but she definitely came into the room and talked with me sometimes while I was doing little, local procedures in the office and whatnot. So you can do it in a way that it's very respectful and everything. So, but go on.
I wanted to be a surgeon probably in high school. It clicked. So then I had to start getting my stuff together. And so that was the plan all the way through. And I stuck with it. So I went to undergrad at University of South Dakota and medical school there, and matched in general surgery at Hennepin County Medical Center in Minneapolis. And then when I finished that, I started here in 2016. And interesting, they hired 2 surgeons on the same day. My partner, who is from my medical school class, Jacob Schaefer, who graduated from residency in Gunderson. Mm-hmm. So we started on the same day, which was a pretty bold move on their part, but it has really paid off because, there's been a few retirements and a few that moved away. So we've kind of kept everything going strong.
Yeah. And were you guys planning on coming there together, or was 2 independent negotiations?
I took 2 independent negotiations. And when I heard he was coming, I was like, great, sounds good. But we got along very well in medical school, but that has been, we could talk about mentorship and rural surgery and how important that is, but that was really helpful to have like a partner in crime, so to speak, going through that too.
Yeah, I could see that going really well, and I could also see it going not so well, depending on, if you're equally matched, training and skill wise, and how your attitude is. So that's awesome that you guys are now basically almost 10 years and 9 years out and doing what you've done. You told me some numbers like that your productivity is extremely high and you're just both very busy surgeons. So there also has to be enough volume to go around.
That's correct.
Which clearly you guys are, that goes for multiple things. So the community has to trust the hospital to stay there, right? And you have to have enough people. So, right at this point, is it just the two of you doing general surgery there, or do you have others?
No, we hired a partner this year. And then there's another clinic in town with a general surgeon too. So it's a little unique in that. But so there's 4 surgeons in town. And 75,000 people catchment area, probably would say, somewhere in there.
Yeah, I read a study that said that the need for a general surgeon, the current general surgeons to population ratio is 1 to 19,000. But they said, well, we're underserved and we need 1 per 14,000 population. And just in my own, the area that I'm at, I came into a practice where there are 2 surgeons, 12,000 in the county. But that's also different because there's hospitals right on the edge of the county in all directions. So that's your like true small catchment area. The thing is, I grew up the next county west. And so I immediately went there and started telling all the primary care docs where I was, what my plans were, which I wanted to come to that hospital at some point, but they're part of a chain and everything. And so I got a lot of referrals from that area early on. I was busy enough, but it's led to me looking at those numbers and like, how much do you need? So 75,000 for surgeons, that makes sense with that math. But the other thing is a rural surgeon is doing maybe a little bit different practice. So I don't know what you can talk a little bit about what you do, but like most rural surgeons, I would say not doing esophagectomies, Whipples, liver resections. There might have to be doing rectal surgery. And so there's things that are in general surgery, lobectomy, vascular, that they don't do. But then you also are a lot of times a GI doctor as well, which you kind of mentioned to me,
absolutely,
as well as other subspecialty things. And so that's my question. Does it really need to be 1 to, it kind of depends what you're willing to offer to your town, I think. If you're just saying, well, I'm just a classic general surgeon, hernias, gallbladders, but I'm not going to do the big time trauma and the other stuff, then you wouldn't be able to maybe maintain the busy practice that you have.
Yeah. You need more people unless you have some other things that you're doing, like endoscopy or GI things. And there's a lot of things to fill in. But
so for your practice, what are the things that get sent out like from classic general surgery? And then what are the things that you may do that an urban surgeon doesn't?
Oh, okay. So let's just start with like, what do I do on a regular basis? I'd say about 75 to 80% of my practice is endoscopy based. So, and at least that. And then what am I doing on call? So you're doing acute care surgery. That can be about anything from bowel obstructions to GI bleeds to, we try to keep a lot of that sort of thing. And then head and neck, some thyroid, parathyroid. I know thoracic really. My elective practice has a lot of like benign foregut, including endoscopy, colonoscopy, and bowel resections, colon resections. I'm not going to be doing any hepatobiliary type things. No thanks. And really need to be in a higher volume center for that anyway. And then like low rectal cancers, I'm not doing that. Then I'll send that out as well. Vascular, I don't do. So, and then like occasionally some weird stuff will creep in. Like I'm the guy that does the below the knee amputations. I don't know how that just things like that. I do a lot of vasectomies in the office, stuff like that.
Mm-hmm. Do you do any GYN?
No, well, we have 3 GYNs in our town. So
any ENT?
Just the thyroid, parathyroids, and the ENTs is one of my good buddies. So we've got one in town.
Okay, and then do you do carpal tunnels or hand stuff or?
No, the orthos have kind of found that niche, so I never really felt like trying to fight over those. So
yeah, that all sounds good. How about varicose veins?
We started doing them, and then it was just like we weren't doing enough because the vascular guys that were coming in, they come in about twice a week. We're doing some, and there's like a vein clinic in the area that was doing some, so it was just really like not enough. But so no, I don't do veins.
Got it. Well, that is a pretty good introduction. I feel like I'm there with you. I kind of understand. And, somebody like you, to ask a question, it almost seems like, why even ask the question? But the next question on the show is, why is rural surgery special to you? So how
Yeah,
would you answer that?
these are my people. I grew up here. I love it
Right.
here. So, and I've kind of thought myself, like, I really love surgery. I love technically, like getting really good at something. It's like, uh, art. It's like art. I wonder if sometimes I'm like, man, I wish I would have maybe done a fellowship and gone to a bigger city. But then I'm like, no way. I don't want to live in a bigger city, and I'd much rather live out here and serve my community. So
What would you miss the most if you lived in the city?
I, well, I would miss a lot of things about it, but the city's just not for me, really. The hustle and bustle and the craziness of living in a city. I like the quietness and I like to be able to get out in the country and I hunt and fish a lot, but getting on the lake, stuff like that, I would miss a lot.
So do you have like childhood friends that are still living in the area that you keep
Oh
up
yeah,
with? Yeah.
it's my hometown. It's just good and bad. Sometimes it's like 1 degree of Kevin Bacon. If you don't know that person, you know somebody that knows that person, and that can make things very difficult sometimes. But on the other side, it really makes you care. You
Yeah,
know.
sure. I had one person come on the show that said, how did they phrase it? The peer review for a rural surgeon is actually just like Walmart and McDonald's because you walk in there and everybody knows what operation you did on whoever and how they did and all that. So, but and
That's
your
fun.
dad, the place where he grew up, how far was that from Watertown?
Oh, that was about 3.5 hours. That was in the middle
Okay.
of the state. But
Yeah. How about your mom?
well, she grew up in a small town near there, and she's also a physician. She's in internal medicine. She's kind of a pioneer of women getting into medicine. So she, but she lived about an hour, 2 hours away from here. But it's kind of same area as my dad, but different little small town.
And your spouse, what does she do?
She's a physician assistant, and I met her in Minneapolis.
Okay.
See,
So
she's
she's
from a
not
small
from that
Minnesota
area?
town.
Okay.
Yep.
So a lot of
I
times
drug her
that
kicking and
drives.
screaming here, but she
Okay.
loved it now.
Okay, great. So my situation in Indiana is, I have my mom and my dad grew up in adjacent counties to the county that I grew up in. So this is all kind of a triangle where it's not just me, but like my great great grandfather immigrated at age 12 as an orphan from Germany, and I guess he had some aunts. And from the way I understand, at least the way that I tell the story is they put him on a boat and said, "You have cousins in Indiana, go find them." And he
Yeah.
got over here, and, so it's like really deep. I've taken care of like my mom's former bus driver, her former babysitter. Just today, I had a patient. They said, "Do you know so and so that goes to my church?" And so we're like, it's just every single day is like that. The
Yeah.
1 degree, it's 100% true. So. Okay, that explains it, which I kind of already assumed, but fair enough. Let's move on to the next segment of the show called How I Do It. And here we're going to talk in extreme detail about how you do some particular operations. And we're going to talk about laparoscopic surgery today, mostly foregut. We may touch on colon, and then we may touch on how endoscopic management plays into some of these things for you. But
Hmm.
why don't we start with the laparoscopic foregut and just give us some sort of numbers and scope of practice and what are you doing?
Okay. You know what? In the past 2 or 3 months, it's gotten a little slow. I don't know why there's a little low, but so like I said, endoscopy plays a big role in my practice. And when I started it was like, what do we do with these hiatal hernia and GERD patients? Because in our area, there was no one really doing anything. And it was a lot of just, you get a PPI for life, and that's what you get.
Right.
Um, I was encouraged to go to this course in Hawaii, the Foregut Disease Foundation course, and I went to that with my partner, and it was very eye-opening. It's like it just kind of put everything together for me. Like, why are people getting GERD? What is a hiatal hernia? Why does Barrett's develop? You know, and really deep diving into this foregut issue. So that was really revealing to me. So when I was doing these endoscopies, I was finding like a lot of these just smaller hiatal hernias, these monsters like intrathoracic stomachs, and so there was a lot out there for us. to do. But I guess I've kind of went off course here a little bit. But steering back in, what did you want to, like
No,
how we got
so
into?
the primary operations that you're doing is you're probably doing fundoplication for
Yep,
anti-reflux. Are you
yep,
doing any LINX?
yep. Um, the common procedure for me to do is like a laparoscopic uh, hiatal hernia repair with the LINX or a partial fundo. Is I would prefer that over a full fund application, honestly.
Yep.
And occasionally like a full Nissen. Um, and
Yep.
yeah,
And are you
that's
doing
kind of the
any
bread and butter
TIF?
there. And not doing any TIF.
Okay.
No,
And you don't do bariatric surgery, right?
no.
Okay. And then are you doing anything to treat like achalasia, like doing Heller myotomies, or that's such a rare condition?
It was such an infrequent thing. I just felt sending those out to someone that actually does them more frequently.
Yeah.
Yeah,
And
but
so
I
what
will
kind of
occasionally
volume?
manage them endoscopically with like Botox and dilations because a
Hmm.
lot of I'd say half the achalasias I found were really not surgical candidates anyway. So,
So if you would say like this is a right down the middle, most common foregut patient, how do they present? How do you work them up? What operation do they get?
okay, yeah. Um, just a classic GERD refractory to medication or having reflux for 15 to 20 years. They may be coming to me for just their screening colonoscopy, and we add on an upper endoscopy because of those risk factors, and we'll find a small hiatal hernia where there's about 3 to 4 centimeters herniated up into the chest, maybe some short segment Barrett's, maybe not. Um, with these patients, I'll typically work them up with a manometry. Um, that's honestly, we can do Bravo studies as well. We do those frequently, and so that's a pretty common thing for us to
Do
do.
you do your own manometry?
Yep,
Okay.
yep. It seemed
So
like it would be a lot to learn. It really wasn't. And same with the like Bravo studies. I didn't think that was that difficult to learn.
yeah, how did you learn it? I send it
It's
out.
I well at that Foregut Disease Foundation course that I was, they have special sections on learning manometries, and just through kind of some of those courses, you just picked it up.
Yeah, very good. And then obviously when Bravo came out, then you started doing that. And what else, is there? You doing an upper GI on these people too with barium swallow or something?
I don't routinely do that. No, my partner will like to throw in like a marshmallow bagel study, which is kind of an assessment of proper motility, but I haven't really been doing a lot of that.
Okay. Do
Yeah,
most of the people you feel like at some point get a CT scan of the upper abdomen, or not necessarily there either?
not routinely, but man, a lot of these people have CT scans anyway. It's amazing how many times people come to me for reflex things, and as they're sitting in the office, I'll just like scroll through the chest CT that they had from 9 years ago, and it's like, yeah, your stomach's in your chest, so
Yeah, and
that's maybe why you're
nobody's.
having some of these issues.
I know. I have the same thing here, and that's where I'm on an island out here. That's why I love this podcast because I get to pick the brain of like bright people that are doing good work all over the country. Um, but I almost feel like, am I doing the right? Like, am I crazy or are they crazy? Because these people are just being, like you said, thrown on PPIs for life or told that that's like part of life, and they had this hernia and no one else is fixing it. So like I almost say like, am I not supposed to be fixing it? I mean, I
Huh.
am. I have been doing more and more of it,
Yeah.
and patients are so generally so happy. Um, but I'm sort of, imagine me 4 or 5 years behind you, and
Yeah.
kind of going through that. I had to get my practice off the ground, and then this has become something that I just see more and more of, and so now I'm doing it. I think most of the primary care doctors around here are like, sending patients to me, but and they're starting to see their patients back that have good long-term results. But basically, if you see it, you should offer the patient the option, right? I mean, even
Options. Yeah.
yeah, right.
Yeah. That's just the thing, because it's like, well, who do you operate on? Well, you don't operate on everyone that has GERD. Okay.
Right.
No one has time for that.
Right.
I operate on people that are really have a strong desire to get off PPIs, or their symptoms aren't well managed on PPIs, or maybe there's some other things that they've got going on, like long segment Barrett's. I want to get that reflux control because I will ablate them later. Honestly, we can talk about that later.
Mm-hmm.
Or so like dysplastic Barrett's or long segment Barrett's, or if they're anemic with a big intrathoracic stomach and have those camera erosions and bleeding issues with that, or if they just have a really large hernia and they're like relatively young and healthy and not comorbid, because eventually they're going to turn into that 85-year-old lady that's got medical issues and anemic, and I see that a lot where it's to the point where it's like, ugh.
Yeah, and then they lose all that extra fat when they get old, and the stomach gets further up there and more mobile, and then it twists, and you got your black stomach, and kills them or whatever.
Get volvulus later. So, yeah.
Okay, great. So that person will say it's a patient that's had Barrett's or they've had reflux. I'm sorry, not Barrett's, reflux for a decade or whatever, and they're like in their 40s or 50s, and they have a 4 to 5 centimeter hiatal hernia. How does that discussion go in clinic in terms of when you're giving them the options?
Mm-hmm. So in my practice, it's typical that I will, opt for just like a partial fundoplication versus the LINX for surgical management. And if they're morbidly obese, then I would discuss the referral to bariatrics as well for those patients. The discussion usually we'll talk about the surgery, the risks. So partial fundoplications find much less dysphagia and gas bloat and changes in like long-term changes in diet and eating habits, but comes at a cost of probably a higher recurrence rate of your hiatal hernia. And in my experience, I've had more reoperations on partial fundoplications or fundoplications in general than the LINX. So the LINX I talk about, they have a quicker return to a regular diet, but it comes at the expense of a little bit more like long-term dysphagia. So I end up dilating about 10 to 20% of these people at some point. So it's a real thing. It's a big speed bump for people. So I try to have that discussion with people, and I still have patients that come by and they're like, I can't believe it. We never talked. It's like, yeah, we talked about this. It's a thing. So, but the LINX, I can understand, especially surgeons, like, why are you putting a foreign body around the esophagus? That initially made me very nervous, and for good reasons, like the angel chick and all that. And we probably put in over 500 to 600 between my partner and I, and we've had one erosion, and that was actually not that hard to manage. I think we've taken out 8 or 9 of them as well, so it's going very well. But
wow, yeah. So how'd you manage the erosion?
Well, there was supposed to be an endoscopic scissors that you could just clip the bead inside the esophagus and let it retract out, but nothing we could get would cut it. So we ended up just doing a like laparoscopic gastrotomy, pulling the bead, cutting it laparoscopically, and we were able to get. What you don't want to do is create like a wide open hole into the esophagus. So we just let those be, because they'll retract out of the esophagus and into like this big scar ball around the LINX device, so it won't be a free leak. And then we just closed the stomach, and I think we came back later to remove the rest of those beads. But
okay, and you're doing all of these laparoscopic, not robotic, correct? Or are you doing
correct?
more?
Yeah, we don't have a robot at our facility.
Yeah. So why don't we, first off, let me clarify a little bit, because I had a little debate about this with somebody recently. Most of these are like, if it's a 4 to 5 centimeter hiatal hernia, how are you measuring that? Are you endoscopically marking where the diaphragm is and then where the GE junction is, and the distance between those is the size?
Yeah, that's a great question. So you can see the pinch of the diaphragm, like 40 ballpark is kind of like where that's typically at. And then the length of the true GE junction. But that's going to be difficult, because if you've got a longer segment of Barrett's, you will see the Z line, so you can potentially get 3 different marking points. So it can be quite tricky. And honestly, it's not very accurate to do it endoscopically. You're never really as accurate as you think you are, but because things move, or those So you could get the measurement of the diaphragm, the measurement of where you think the GE junction is, based on like a little pinch there of the lower esophageal sphincter. And then you could get the mark of the Z line, which is even more proximal to that, depending if they've got metaplasia. So,
Yeah, that's exactly the case that delayed me getting to this interview. Well, it's not that; it's that there was a gallbladder before that was pretty nasty.
Yeah, it's okay.
But my last case that I did this morning was a EGD for longstanding GERD, and her diaphragm was at 39 centimeters, but she had salmon tongue peaks of peak mucosa tongues that were extending up with a total irregular and a couple rests of tissue like that. So, I mean, I'm very suspicious for Barrett's. That would be a new diagnosis for her. And I took, so we can actually, I got a question about what you would do there, but then I measured that up to about, clearly there was a hiatal hernia, but measured that up to about 34 centimeters. So anyway, I end up saying 4 to 5 centimeter hiatal hernia. But like you said, you don't necessarily know. I ended up doing 4 quadrant biopsies from I guess I didn't really see the pinch of the esophagus, but you would try to do that from where you think the end of the esophagus, the GE junction actually is. Or, I mean, how do you know you're not getting fundus in that biopsy?
Okay, let's go on a little side track on this one. So, how do I manage my Barrett's? Or just like, how do I biopsy Barrett's in surveillance? I'm biopsying with cold forceps, like the Z line for sure, and I'll try to biopsy near like the true GE junction if I can tell where it's at. Like those are going to be your highest incidence of finding like dysplasia in those areas. Like a true Seattle protocol, if you're doing that, like I just diagnosed a guy with like 11 centimeters of Barrett's like this week. Nobody's doing that. Like
that would be 40 biopsies.
Yeah, 44 biopsies. So
yeah,
I have incorporated Watts 3D into my practice a lot, which is really helpful and it's easy to get going. But it's a brush biopsy, so you're brushing the entire area, and they've got really good data on being more sensitive in finding dysplastic Barrett's, and doing a better job than Seattle protocol biopsies. So that would be, if you're doing a lot of this in your practice, it saves a ton of time. It's really nice. So it's kind of an adjunct to your cold biopsy forceps. But
okay.
yeah.
And do you surveil Barrett's every 3 years?
Just depends on if it's a really long segment, that might be 1 year. If it's a history of dysplasia or if I've done ablations on them, it might be 1 year. But if it's just a short 1 centimeter tongue of Barrett's in a low risk patient, that's going to be 3.
Okay. And then when you go in to do that surveillance, then if it's really short segment, you still do biopsies, or do you always use the Watts 3D brush?
I will more likely than not use the Watts, but sometimes it's just like so minimal that I'll just like, you're pretty much getting everything with your cold biopsy forceps.
Right.
But remember, some Barrett's, especially in women, will hide well below that Z line, and that Z line will look nice and might only show 1 centimeter, but if you go beneath that, you can still have Barrett's. So, yeah.
Okay. All right. Let's see. Where did we leave off? So we got the patient so the next question I had was, how do you classify that? We've been using the word hiatal hernia, and I think we know what we're talking about, but paraesophageal hernia. How do you classify that paraesophageal hernia?
I don't know. This, when the insurance company wants me to say it that way. It's kind of all the same disease spectrum, right? And it's kind of hard to tell what exactly you're dealing with, but is the GE junction slipping up into the chest, or is it slipping alongside? Is the stomach slipping up alongside the esophagus? I don't know.
Right. Like the thing is, a type 2
is paraesophageal hernias, but it's to me, it's the same disease process, and it is what's this cause of the reflux. So
it's technically a type 1 sliding hiatal hernia codes as just an anti-reflux procedure.
That's right.
But a type 2, 3, or 4 paraesophageal hernia codes as a paraesophageal hernia repair. Well, type 2 I kind of get, but I don't really see that many type 2s where it's just an isolated loop of the stomach going up. But a type 1, like at what point is it a type 1 or is it a type 3? Like when it's 5 centimeters and there's a bubble of stomach up above the diaphragm, like clearly the GE junction is displaced up there, and that's a type 3. But when it's just 1 centimeter and it goes up and down, like somewhere in between those two is now a type 3.
Yes, it's kind of a conundrum. What I care about is that if it's sliding, it can still be the cause of this reflux issue. We're kind of potatoing a little bit with that, and maybe the definitions need to be more clear. But I hate that insurance companies have kind of picked up on like, oh, is it this type or this type? And it's like, well, it's kind of a spectrum. It depends if the patient is hiccuping right now or inhaling or breathing in or not. I don't.
Right.
So.
But then there are some patients that truly do not have a hiatal hernia, and then those you're still doing those anti-reflux surgeries, and then you're billing it as the other one.
Yeah, and those are a little bit. They will not get covered for LINX, so those patients will almost strictly get a fundo.
Okay, so. And you keep saying fundoplication and partial fundoplication, but what fundoplications do you do? Nissen, Dorr, Toupet, what else?
I'm more of like I have been doing a lot more like Watson's, which is like kind of like a Dorr plus a little bit. I guess it's a little bit like a 180-degree anterior, but my partner is doing like Toupets. So I've seen pretty similar results between the two of them, but just less. We're looking for less dysphagia postoperatively and a little bit less gas float and dumping in my experience too. But
yeah, I got to be honest, the Watson is a new one to me. So I'm looking it up as we speak.
Just think Dorr, but you're getting it to go about 180 degrees anterior, and you're almost getting down to the preaortic fascia and the right side of the esophagus, and you're kind of tacking it to the hiatus as well. For 180 degrees.
I see the Google image here. Picture's worth 1,000 words. How many stitches do you use on your typical Watson?
Let's see. I'd have to.
Like this picture on Google says about maybe 1 on the left side, 1 at the top, and then like 4 off to the patient's right side.
My guess would be 6 or 7.
Okay. Yeah. Makes sense. And we'll talk in more detail because I really like to, if you want to ever humble yourself, start a podcast about surgery and expose to the entire public everything you know, right? Because it's not everything. But
this stuff can be humbling the way it is, so I don't know if I need to.
Yeah, easy to get cocky in surgery, hard to stay that way, humbling professional, all those things. Yep. But I could talk about this all day. So let's get to like the nitty gritty of this operation. Okay. So you're going to do we'll call it a type 3, 5 centimeter paraesophageal hernia repair. And you take the patient to the operating room, and how do you position them and where do you put your ports?
Okay. So I'm a supine guy. Nothing fancy there. So we get everything prepped. I don't really ever have an endoscopy available either. So some people like to scope everyone, and I don't routinely do that.
Do you tuck the arms?
I tuck. No, I don't tuck the arms. Not for this. Okay. So,
and which side do you stand on?
I'm on the patient's right.
Okay, great. Because I put them in lithotomy and I stand between the legs. So,
and that's a preference thing.
Different ways to do it. Where do you put your ports?
Okay, so I'm going to Visian and really laterally underneath the left costal margin with a 5 millimeter port. So it's almost as far down as the ribs will go, and so I use a lot of local and I Visian there. And then I'm going to I measure using my knuckles, right? So if I have that much distance between my ports, I'm happy. I'll put a 5 medial to that. And then I'll put a 10, about another knuckle. It's basically going to be straight above the umbilicus. Some people's anatomy is really different, but it's usually somewhere between the umbilicus and the xiphoid with that bigger 10 port.
Mm-hmm. But it's in the midline.
It's usually in the midline, yep. Sometimes it'll be alpha to the right. I don't really care if it's midline or not. It's just usually there. And then another 5 is going to be like subxiphoid. That one usually actually comes through the falciform where it's thin over the top of the liver, typically. And then I will take the trocar, like the inside of the trocar, the introducer, and make a little poke hole on the right subcostal margin and just put the trocar in, and then I can advance my liver retractor through that and secure that. So I don't even use a port for that.
Okay, which liver retractor do you use?
Oh, it's
Is
that
it
heart
what?
shaped. It's you get screwed up and it's in the heart shape, but I can't remember
Okay.
what the exact name of it is.
So it's not rigid. You don't have to like do contortions to get it in. It's just straight. You stick it in, then you twist a thing to make it go into the heart shape.
It's pretty soft, and then it's kind of a snake, but it'll snake into a heart shape when you
Yeah.
start tightening it up.
Yeah, I use one
So
that looks like a triangle, but same concept. But I put it through a 5. So maybe I'll have to try this new
you can save the
tip.
hospital, whatever 5 port costs. So
Yeah. And your camera then goes through that. Where's your camera most of the case?
my partner is going to be on the patient's left side,
Uh-huh.
and they're going to have one retractor and the second port that they put in, which is going to be kind of in the middle of the left abdomen. That's their camera port.
Mm-hmm.
So my right hand is going to be using that 10 port, and my left hand is going to be using the subxiphoid port.
Sure. Okay, and then you're going to put the patient in reverse Trendelenburg.
Yep.
And you've got probably 15 of insufflation, and
yep.
you're going to start your dissection where in the pars flaccida.
That's right. So the depending on how big the hiatal hernia is, their assistant's doing some good retraction there, and it's usually my partner, so I can trust him. So there's no Penrose ever involved in that, but there could be if you were worried. But so I start in the pars, and I work my way up. Right, I'm trying to shoot straight for the right crura. Because once I get onto the fascia of the right crura, I'm going to work my way just on the inside of that crura until you start getting the great wispies up inside the chest. That's how you know you're that's the sweet spot. Everyone loves
harmonic
those wispies.
Or ligature or what?
I'm a ligature guy.
Yeah, same here.
Yeah.
The 5mm blunt or what? Which one?
I like the 5mm Maryland. Personally.
Maryland. Okay. Yeah.
Yeah.
Okay.
Sometimes you'll come across, and when you're doing that dissection between the pars and the hiatus, there'll be a little accessory vessel that goes to the liver too. I've had to spare a couple of those, but I usually will take that if it's small. So, but once I get into the chest and you get the nice wispies, then I'm going to go anteriorly over the top of the esophagus and work my way, try to get that upside down smiley face to get the front esophageal attachments off right there. From there, to get to the left crura and get those attachments off, especially if I'm doing a fundoplication, I will just start going for the short gastrics. I don't do that for a LINX, but in a fundoplication, I will just back off and go back to the fundus and get those short gastrics and take that plane all the way up to the left crura, because it just shows the backside of the stomach so much easier. And remember, when you're getting close to the hiatus, there's 2 layers of short gastrics there, so you think you're done, but there's usually one more short gastric in the way back that you got to be careful on, because if you rip that, it's just in a bad spot to get to. So, but if you take that one up into the chest, you're now posteriorly in the perfect plane to take off that last esophageal ligament on the left crura. That's
what
usually
if you
the
do rip
tightest
that
spot.
short gastric?
Well, just you're probably just gonna be able to get it and just pick it up and burn it there, but
retract, expose. Sometimes you break out the sucker. Do you use a sucker regularly?
Yeah. It's not open routinely, no, but
yeah,
it's in a hold bin.
Grasp and burn.
Yeah. Be careful.
Yes.
Step 1, panic, right?
Yes, right. So, don't panic and freak out. Okay, so then you basically up.
My goal is to get 360. Yeah, get 360 around the G junction if you can. It really that depends on how big the hiatal hernia is too, but you're trying to get into that wispy plane, almost sides. All the way around the esophagus, and the posterior esophagus. You get into kind of that mesentery, getting the lymphatics and off the aorta.
Mm-hmm. Talk to me about the phrenic nerve.
Yeah.
Or the vagus nerve, I should say. Yeah.
Yep. So you can, oftentimes you get in the wispies and you're going to identify the phrenic nerve. It could be, it's kind of all over the place.
I got sometimes. You saying phrenic nerve. We're talking vagus nerve.
Just trying to catch me. It's all good. Just to know So I try to identify it wherever I can. And so if I see it first up in the chest and all those nice wispy tissues, then we'll kind of trace it down. But we'll go out of our way to try to find it. But once I have it, I will kind of isolate it, push it towards the esophagus, and then work underneath it to lift all that tissue up and away. But and then with a LINX, I actually want to make a window between the phrenic and the esophagus, or not the phrenic. Now you got me saying phrenic.
I know. That's my bad.
I want to make a window between the vagus and the esophagus because that's where the LINX will eventually go. So I will sometimes just take that opportunity. So now that we've gone way up into the chest and those wispies and it kind of reduced the stomach and gotten the esophagus down to where we want to be. That's when I think about just closing this. So I'll be honest, I'm not a mesh guy in the hiatus. I think the pendulum's kind of swinging back that way too, but I will occasionally put a mesh in if it's just really thin tissue or it's really got a lot of tension on it. But most of the time, I don't. If there's not a lot of tension in that crura, I'm not using a mesh.
Yeah, that was really beat out of me at my training at Mayo because, of course, they're getting like multiple states or actually the whole country kind of getting referrals for mesh problems to them. I mean, they just told me never, ever, ever. And if you have to put a mesh to make an incision laterally in the left diaphragm and like a relaxing incision and stitch your mesh in there so that the tension comes off and you can close the hiatus primarily. I did see that once in training, but I've never actually seen any mesh placed at the hiatus, nor have I ever placed any myself.
Mm-hmm. No, I usually just get good big bites of my Surgidac endo-stitch suture, and I'm not trying to take little dinky bites, but I'm trying to preserve the fascia on those crura when I'm doing the dissection, and I'm getting a good amounts of tissue when I do those, and not incorporating the aorta or something else. Just so 2 or 3 stitches is 95% of the time it's going to get that those crura together.
Yeah,
without pinching the esophagus together.
The one I'm thinking of, it's a giant type 4, huge defect, 10 centimeter defect or whatever, and it's just going to be so much tension. But I've also heard that now might be. The other thing is I might be perpetuating black pearls of false wisdom, but I heard that Dr. Demeester would induce let me just see if Demeester come on my podcast, induce a pneumothorax to cause
That's correct.
It to fall down.
I've heard him say it.
Okay, so good. So confirmed. So, and then that pneumothorax would be on which, does it matter which side or could it be?
Patient's left, probably.
Patient's left side. Okay. And then that would allow it to come down with less tension, at least while you're closing right there. Now you're using
There's all sorts of tricks
what?
That you can use in this. Yeah, there's a lot of different tips and tricks in this that you can use in that area. But I close it with an O-Surgidac.
And do you do like figure eights or simple interrupts or
figure eights? I love the figure eights. I think it just distributes tension nicely through there.
I agree. That's actually exactly what I do at the end of stitch. And so then give me a couple other tips if you got a lot of tension. You already mentioned the following: save the fascia, take big bites, distribute tension with the figure of 8. We talked about the inducing pneumothorax thing.
Yeah, if that doesn't get you where you need to be, then that's when I'm considering mesh. If it's really tight or I can see my stitches are kind of pulling through, that's when I will use like a phasix mesh. But phasix is definitely going to induce a big inflammatory response and have a lot more dysphagia too. So
how do you shape your mesh and put it in there then if you were going to use a phasix?
Mine's kind of like like a big circle with the hole in the middle of it pretty much is, or like an upside down U, but it's going to be connected at top. And I'll stitch it in on the inside of the crura or like over the top of my previous stitches. And I will use a tacking device, but carefully. Like I'm looking for the vessels underneath the phrenic vessels because there's usually some bigger vessels on the underside of the diaphragm. But I'm definitely not going to tack towards the heart or downward, like posteriorly. Yeah,
I mean, I've heard of a pericardial fusion and things happening with tacks in that area. So that phasix, is it that you're using? Is it pre-made to be placed in the hiatus, or are you cutting it like that yourself?
I'm cutting it like that.
Okay.
There's one that's sized pretty appropriately, though.
Yeah, and so it's kind of like a keyhole, right?
Yep.
In a circle. How big is the hole that you're putting? Is it like 2 centimeters or?
Yeah, 2.5 centimeters.
2.5.
I usually want it kind of just around the esophagus, but not touching or putting pressure on the esophagus.
And the tails will come up anteriorly, like to come together. You don't put them behind, right?
Yeah. And try to just get them to overlap just at least a little bit.
Okay. Yeah, those are great tips. Anything else that you want to share technically about that component?
No.
Have you done any without your partner?
A few. Yeah.
How'd it go?
It's so much easier with him, man.
Yeah.
It's just, you don't even have to think. He just like the exposure's already there. It's just fun, but it goes fine. We have a PA too that can do those things, but there are certain ones that I wouldn't. I just have them there, like the bigger intrathoracic stomachs, and if someone's really obese or something, I would have them there. But yeah.
Have you ever had to convert to open?
No.
Okay. And You've done hundreds, sounds like.
I would say probably 800 to 900 foregut surgeries in 9 years.
Yeah, well, that's fantastic. I had one that it was a type 4, and of course it's like a teacher at my school and all this stuff, and it was stuck. It was stuck up there, like it was incarcerated, and I really felt uncomfortable laparoscopically. And I ended up placing an epigastric hand port and reducing it that way. Which I'm not telling anybody to do that, but you find yourself in a situation and it's like, I don't feel safe doing anything, more. I mean, my other alternative is like leave it and bail out, but I felt like I was there to reduce the hernia. So
I had one so he had a recurrent hiatal hernia after Nissen from like 10, 20 years ago, so a long time ago. And his Nissen had herniated up in the chest, and it was just stuck on the bottom side of the left diaphragm, like up inside there, and I just could not. It was just plastered there, and he also doesn't have really much pulmonary reserve, so I ended up backing out and just said sorry, And he went. I think you got evaluated at your alma mater, and they said no, you're good. No thanks. But
yeah.
Anyway,
a couple other questions. Have you ever seen or heard of a Belsey Mark IV fundoplication? Have you ever done one?
Yeah, I kind of thought a chest or thoracic component fundo might have been the best way to approach that patient that I just talked to you about.
Right, that's what makes me think of it. So I think I did 4 of them in residency because we had a guy that did a bunch of them. Had a spoon, to throw the stitches like through the chest, and of course he just loved them, and so that would be for a person who's had 2, 3, 4 previous foregut surgeries from an abdominal approach, and you're expecting that to be hostile, and you're trying to get a repair. Any other comments about that? I mean, if you had that patient, then you're sending them to a university setting and kind of letting them make the final decision, or what?
Yeah. Just if I can't do it in my little small town, doesn't mean it's maybe not possible, but just not something I'm comfortable doing here.
Yeah, I don't know. That surgeon,
complications
that surgeon retired. I don't know where I would send somebody to get a Belsey.
Yeah.
Maybe I'll find
There'll be a time where no one's doing Belsies anymore. It's probably an aging thing, but it doesn't mean it's wrong. It just.
The other question I had is, how about management of that 85-year-old frail lady with a type 4 who's symptomatic? And I have something, which I guess I could go first, or you could go first.
If they can tolerate a surgery, I'll do it. I think patients do a lot better. I think it's been a while since I've looked at this data, but we talked about this at that conference once, and they do pretty well with these surgeries. And the typical symptom that these ladies have is anemia. I see a lot of these, and they have been scoped up and down for 10, 20 years for this anemia that they've had forever and ever. But I'll be pretty aggressive if I think they can tolerate the operation. Well, I'll do it, because in my mind, it's almost the recovery for typical one of these surgeries is similar to a lap chole for me. I may not be aggressive with like a LINX or a really tightness, and like that's a different thing. But the gastropexy is becoming a lot more common, or like the old fashioned putting a peg or gastrostomy tube in them just to keep them from reherniating up in the chest I think it's making a comeback. But
Yeah, so that's exactly the patient that I'm talking about, which I did like, I don't know, 4 months ago or so. And it was a lady that was really, really hesitant about major surgery and stuff. And that's what I ended up doing was 2 peg tubes. So I just put it in,
Yep.
put her as steep as I could, head up, drug the stomach with the scope as far as I could. It's really unsatisfying, but drug it as far as I could, and then put my first peg, and then put another peg as 2 anchors. Pulled them in the clinic 6 weeks later. I could not believe it. She was symptomatically quite improved. I think from a safety perspective of her not volvulizing, I would say she's
Yep.
basically totally protected.
Yep.
And so for the right patient, that was the option I was going to suggest.
That's a good real surgery story, because I could totally see something like that being an option at some point.
Yeah, and the other thing that that I do with my fundos is if I usually do a toupee in a younger, healthier patient, but if it's a big like type 4 or big type 3, and especially an older patient, I just assume that they have some esophageal dysmotility. I don't usually do a manometry in that situation. And I just assume that their esophagus doesn't work right. And I always just do a door, maybe a Watson or a door, you should say. But, just an anterior thing to kind of bolster the stomach down there, but not try, their esophagus is not going to push well. And if they have any element of it being too tight down below, then we're going to have a problem. Do you use a bougie?
No.
Okay.
That's like a hard no, because when I'm doing a partial fundo usually, and the worst complications I've heard of from this type of surgery is the bougie accidentally going somewhere where it wasn't supposed to go, or being advanced by someone that maybe doesn't have the skill set to be advancing bougies and causing the problem. So I'm
scared of the bougie. Yeah, got it. No, I use a bougie, a 50 French bougie, and then wrap over the top foot with the partial fundo still. But so how does the partial fundoplication, I guess I see what you're saying, because a full wrap, that's what's protecting you from going too far. But you and I are both still having some patients that are going to require a dilation at some point anyway. Do you think that there's any chance you could prevent a higher percentage of that with something stenting
the partials? I think, because I'm only wrapping like 180 degrees with the partials. So if I was going to do, it's been a long time since I've done a Nissen, but even then I don't bougie all the time either. So
yeah, I don't think I have had any of my anterior partial fundos that have had to dilate yet. Now don't have as many numbers as you do, but the toupees I've had to dilate, I think 2. One guy went and ate a McRib the next day. Like, come on. And then I had to emergently take that out. And it's like, give me a break, man. So do you keep them in the hospital a day?
Most of the time, no. It's just kind of outpatient, and that's the plan. And we talk about that from the get-go. If it's someone elderly or someone comorbid, or maybe you got into the pleura and gave them like and they're hypoxic, but most of the time, no, they go home.
Do you have to do something from an insurance perspective on this? Like, I think I was told by some administrators or somebody that they're like something's on the inpatient only list. So you have to like call them an inpatient?
I haven't had any. I don't know how that's billed or coded, to be honest with you.
Well, anyway, I just mostly have been keeping them overnight, and it keeps everybody happy. But what do you do with the diet afterwards?
With the partial fundos are more of a soft diet. I don't go for 6 weeks of full liquids or anything like that, but softer foods. And with the LINX, it has its own kind of diet where you're chewing things up. They actually want you to be eating about once an hour or something just to keep it moving. And
So if somebody was interested in, like, say maybe they have the skill set to do laparoscopic fundoplication, maybe they have or haven't been doing it, maybe they're not doing LINX, but they wanted to add that to their practice, where would you recommend they go?
Like, go to that Foregut Disease Foundation course just once. It will be very eye-opening to
Yeah, I think I'm going to go in February.
You should. It's great. It's Hawaii in February. There's nothing wrong with that, but It'll be very eye-opening and kind of understand how to think about these things a little bit. But
do you go regularly, or did you just go that one time?
I've gone regularly. I've probably been to 5 or 6. I missed a couple years here and there.
Yeah. Have you ever been to the Comprehensive General Surgery Review course for Mayo in Hawaii?
No, I haven't, because I've always gone to this one and I can only go to one.
Yeah,
But
it's also in February. I think it's like the week or two before this one
yeah,
that you're
they're
talking
always
about.
very close because one of my partners will go to that one or something like. And
Yeah,
some
I
friends are
like
going
that.
to that one.
Of course, it's like a reunion for me. I just go like talk to all these
Sure.
people that I trained with and all that.
Yeah.
Okay, cool. I'm trying to think if there's anything else that I missed. So we walked through. You secured the anterior fundoplication with the same SurgiDac.
Yep.
And you said like 5 to 6 to 7 sutures, maybe a little bit more on the right side. And then basically you're just pulling your ports out. You're letting the patient go home the same day, and they're able to do a soft diet pretty quickly.
Mm-hmm.
And then do you do a follow-up EGD or anything like that? What's your follow-up like?
Only if they need surveillance for Barrett's. Yep.
And the textbook would say that the fundoplication does not cause the Barrett's to regress.
That's.
Do you think that's
I've
true or not
seen
true?
shorts. I know. I've had short segments regress, especially with the LINX. If you got longer segments, good luck. But I've definitely had. I actually would say the majority of patients with like sub-centimeter Barrett's will regress after you control their reflux. But I think there's some papers coming out about that too. But
Okay, good. All right. And I think that's probably, and I don't think we should go to lap colon surgery. That's a lot of great
yeah,
detail.
yeah,
My listener really appreciates it. Maybe I can twist your arm to come back and talk to us about some of that other stuff. The only other thing I did want to ask for the how I do it is that management of Barrett's, and you're doing RFA even. And
yes.
so can you just tell me real quick how that is in your practice?
Okay, so this is good because like one of the things I wanted to talk about is how endoscopy is like it's kind of like all encompassing. Like, what can you provide for this patient? So, like 10 years ago at my institution, it was endoscopy. You've got Barrett's. Put you on a PPI. See you later. Okay, that's it. They weren't getting Seattle protocol. They weren't getting anything. So now we've got options to treat these patients. So when you're looking for it, you will find a lot more. When you know what you're looking for, you find a lot more of this stuff as well. So, um, you know, finding a Barrett's patient, I'm doing cold biopsies. I'm doing a thing called tissue cipher, which kind of looks at the genes being expressed by the biopsies. Like, is their Barrett's tissue expressing like EGF1, or is it more concerning type of tissue? And it will give you like a risk factor of their lifetime risk factor of developing adenocarcinoma as well. So that's helpful in kind of predicting who's going to progress. And then I'm doing the Watts as well to kind of replace Seattle protocol. So in these, I will find some patients that are dysplastic, lower high grade, or these lung segments, which are a little bit higher risk as well. At that point, you can have a conversation with the patient. It's not that hard to convince a high grade to undergo RFA. But some patients are just like, you're telling me that I've got 10 centimeters of this precancerous stuff in my esophagus and we're just going to watch it. That doesn't sit very well with them most of the time. So then we may recommend ablation.
And that's for a person that does not have high grade.
Yeah, that can be anyone that just has non-dysplastic Barrett's with the longer segment, like 5 centimeters or greater. And there is some hoops to jump through with different insurances covering it and not either.
Yeah, and
I've had to write a few letters for those.
Summarize what you said just before that. The 3 things that you're doing for diagnosis is the biopsies, the tissue cipher, and the Watts 3D.
Yep.
And how do you choose when to do, like, basically if you go in and they don't have a known history of Barrett's and you see something that's suspicious for Barrett's, do you do all 3?
Well, if the pathologist diagnoses Barrett's, that'll get kicked out to tissue cipher. So that tissue will get sent to the tissue cipher.
It's the same tissue. Okay.
Yeah, and then the Watts is done when I see visible Barrett's.
Like if it hasn't been.
Yes, even if it hasn't been, if it's the first time, if it's like a 1 centimeter thing, then I may not. But oftentimes you're getting like 3 to 4 centimeter Barrett's. It's pretty easy to tell that's what you got going on.
But you can't send the Watts 3D specimen for TissueCypher, or can you?
I don't think so. No, it's a different company.
Okay. And who drove the TissueCypher? Was it you or the pathologist?
Me.
Okay. And you learned about it at the conference?
Yeah, you know it.
Keeps coming back to this. Very good. Something, and then the RFA, can you talk us through like how it goes through the EGD scope?
Yep. So it's usually the first one's a general anesthesia, so it's a little bit more than what you think. But so you go down with your scope and you're kind of assess the top of the gastric folds and where the Z line is to kind of get a marker of how much you're doing. There are different catheter tips depending on how extensive you're going to get. Like there's one long one that's 360 degrees where a balloon inflates underneath it like a dilation balloon, and then it will apply a burn circumferentially. So that's typically for your bigger or first treatments. And then as the Barrett's progresses in the future, you may, or if there's not very much, you may use some smaller catheters that burn. But
and they just burn at the tip?
They will burn like the side of it. It's like a little paddles. There's little paddles. So,
and these come through your working channel on your EGD scope?
There's the big balloon one is go along the side of the scope, so it's on its own. And one is like a cap that attaches to the end of the scope, and then there's one smaller one that goes through the scope.
And if somebody wanted to start doing this, call a rep, or how would you? Is there a course or something?
You talk to a rep, and they'd probably put you through a course. At least have someone come and you'd stack up a few and do them.
And you
all.
Also brought Bravo to your town, right?
Yep. Mm-hmm.
So you must not have any GI in town.
No.
Yeah.
No, there's not. Okay. But I will say with the radiofrequency ablation, the patients that hurts. They can be pretty like if you ask them what hurt worse, the hiatal hernia repair and LINX or the RFA, it's RFA hands down. Like that hurts. I mean, you're burning your esophagus, so that.
But you still let them go home.
Yeah.
Just with pain medication, and then if I had say 10 centimeter Barrett's, what would you tell me the expected result would be after my treatment? My first treatment with RFA, how many times do I need a second treatment?
It's most of the time you're going to take 3 to 4 treatments at least with that long of a segment. If it's a shorter segment, maybe not, but I feel like you usually get like 60 to 70% to resolve every time you do it. So you're kind of chipping away at it. But the second and third treatment for some reason they hurt way less than the first one. The first one's always that's the one that gets them.
Yeah, and after you're done, when you come back and rescope them, when the Barrett's is gone, you're diagnosing it by biopsy. But how does the lining look?
Like squamous lining.
Normal.
Yep.
It goes back to looking normal. Okay.
Yep. Key is good reflux control. So I typically like to do the reflux surgery before. I had good results with that. Some GIs will do it like the opposite, but
try to get the Barrett's under control, then do that doesn't make as much sense. Okay, well, that is such an awesome practice that you have, and excellent tips that I would say I definitely didn't know everything you said, and so I'm sure my listener would have picked something up as well. Why don't we ask if you've got a financial tip in our financial corner to share with the listener as well?
Don't buy hawk to a coin. That's all I got. I've just been kind of right down the road. I don't try to spend too much, stay within my means. I didn't buy a big fancy house when I came out. I just finally got my first new car this year. So I think you're much more savvy in that department than I am. So,
well, take your time, and just, there's no rush on all that. And most of the studies on that would say that after $70,000 to $100,000, people's happiness doesn't go up per year of annual income. So, I mean, definitely, I would not want to be trying to get my happiness from somebody else by showing them the things that I can buy, But that's great. A lot of our tips are kind of like that. So, and you have a classic rural surgery story for us.
Okay. Yeah. It's a little bit odd, but it's a kind of a fun one. So, I'll just start from the beginning without kind of giving away what happens. But,
Okay.
um, so I'm on call one weekend. I was trying to get this patient with a GI bleed to get her colonoscopy done on a Friday so that I may not have to come and round on her because I didn't have anything else going on at that time. But she's kind of a pain and she refuses her prep. So, but then on Friday she decides that she'll do it. So she preps him over Friday, and so Saturday morning, and it's time for a colonoscopy. I have to wait for the orthopedic doc to get the hip pin. So it's like 11:30 on a Saturday, and it's like summer, like nothing's going on. I'm just sitting there twiddling my thumbs, and then I overhear this overhead page, trauma level 1, ER 3 minutes, and I was like, that's odd. Like 3 minutes, like usually they give you always like a 10-20 minute phone call ahead
Yeah.
of time. So I kind of walk down there and I walk in the ER, like the trauma bay, just as the CRNA is tubing this guy. I hear that he was stabbed in the chest. He's got like one here. I'm like, what? Well, he was already coding, so we've got a thoracotomy set right there. So I asked them to paint or betadine his chest, and I just remember laughing because one of the nurses had 3 betadine sticks and started painting the. So that made me laugh. I was like, "No, get that bottle and just spray it on there." So we did that. It took me longer to find a 10 blade than anything. So I do a thoracotomy and I open his pericardium and get a bunch of blood come out, and there's a little hole there. I put my finger on it, but he's still in cardiac arrest, so I get epinephrine and it just put it right in, and all of a sudden it's like, okay, we're going, it's working. So, and at that point it became quite a pain in the butt because that epi really got things going. It was like stitching like a wild cat. I mean, it was just all over the place trying to throw stitches in there,
Mhm.
but.
So you actually put
So
it
yeah,
through the stab wound in the heart?
no, I did a thoracotomy already. I'm holding on to his heart when I put the epinephrine in,
Yeah.
like through my thoracotomy incision
Where'd you put the epi?
into the heart, like into
Oh,
the ventricles, like in 2 or 3 different spots. I don't remember.
okay.
I just
Got it.
um, but by that point, then my OR crew, which is supposed to help me do the colonoscopy, was kind of like right behind me, and it just happened to be like these solid techs and nurses that are like, my go-tos that can do anything. So we just I put a few stitches in that laceration. It was like right at the apex of the right ventricle, and it was pretty hard to stitch because it was just
Beating like
going
crazy.
crazy. But um, so yeah, then I didn't close the chest. I just put a big IOBAN over the top of it and washed it out really well. And he got sent out to a place where there's actually a thoracic surgeon. So, and then I went and did my colonoscopy, and I got to go
Oh
home.
my.
So, so things happen. It's kind of
So the stab
anything can
wound must
happen.
have happened very close to the hospital, or what?
Oh yeah, yeah. So the fire department's about a mile away, maybe, and they were holding an in-service for some of their equipment, and he got stabbed like apparently like less than a block away from the fire department. So all these paramedics are outside doing their service, and he didn't even make it to their like he collapsed in like the street out in front of the. So they just um pulled out an ambulance and threw him in and just brought him in. So
Unbelievable.
it was he's
What
so
kind of
lucky. There's so many things about that guy that it's like so
did he?
he
So he
was
made it?
yeah he lived. Yeah.
Unbelievable. Thanks to you. That's amazing. So tell me how you did your thoracotomy.
Uh,
Like it wasn't a sternotomy; it was a thoracotomy.
no, just left lateral, like nipple to, as far back as the bed goes, and just 10 blade down to ribs, 10 blade over the rib, hands in, pull. I
Do
had
you
to
have
cut
a
2 ribs.
retractor
Yeah, we
in
actually
the?
had a thoracotomy set in the trauma bay.
Okay, and then
Yeah.
you're saying I'm sorry to cut you off. You had to cut some ribs with. You have a rib cutter down there too. Then
There's a rib cutter in the trauma in that thoracotomy tray, so I cut 2 and just put the rib spreader in and spun it around, opened it up, and I was able to get my hand in there and
and open the pericardium. Any tips for the opening the pericardium?
just stay anterior if you can so you don't get back and get that phrenic nerve.
There you go.
For our listeners that have been listening the whole
Going full circle. If there's a listener, it's one person, right? And their earbuds. And I only talk to one person at a time, so it's fine.
I had done it a few times because I was at Hennepin. I actually had one successful one and an 18-year-old back then, and 3 or 4 not successful. So, but
yeah,
that's just the way it goes.
Right. And what kind of stitch did you stitch the ventricle up with?
That was an O-proline because I needed a really big needle. Yeah. So
I've heard of people taking
almost had to do a mattress.
Foley and blowing it up and sticking it through the hole so that they can control that bleeding. Did you do anything like that?
That might have worked, but my thumb was just like perfectly sealing that hole, and then I was able to get a Satinsky on it actually, and that held it. So I just was able to. I tried to put a couple mattress stitches in, but it was just in such a spot that it was like really difficult to get that to hold. So I just back and forth, just imbricated back and forth and tied it down. It was like
over
okay,
the
and that's
Satinsky.
what finally held under it.
Oh, under the Satinsky. Yeah, sure. And then did you use any pledgets?
No, I didn't have.
Do you have pledgets? Yeah, I don't think we have pledgets where I'm at. That's for sure.
At that point, to have someone go try to find a pledge, it would have been like, no.
But I've heard also. I think I've heard of people using the pericardium as a pledget too.
Yeah, you probably could. It actually, the key is just not cinching down so hard that you're just ripping through all the tissue. Like it's got to be just lay down that knot nice. And maybe throw it. Yeah, that was the.
What a crazy case! And are you a level 2 trauma center then?
Yeah, actually, I don't even know if we have a designation. We'd be more like a level 3 or 4, but I'm the trauma director. It's more that the hospital just doesn't want to pay for an accreditation because it doesn't really add to the bottom line than anything. But
but when it's there, I mean, it's amazing that you were in-house. I mean,
I was so lucky. I mean, there's so many things about that guy's story that were just like the stars and moon and the galaxies aligned so perfectly for that guy.
Everything except for the stab that morning.
Except for getting stabbed.
That was really not fortuitous. All right. Well, this has been my pleasure and my treat. Thank you so much for coming on, Dr. Gerrish.
Yeah, it's been fun. I'm going to go outside. It's a beautiful South Dakota day now, so get to go lake time.
Yep. Keeping you out. That's awesome. All right. Thank you again to our listener for being here for this episode of the Rural American Surgeon. Don't forget to give us a like and share this with the people that are in your circle, especially anybody that's interested in rural surgery. We're trying to create a sort of a surgeon's lounge for the rural surgeon to talk about these things that I don't know about you, but I don't have a lot of opportunity to talk with people about this, just sitting around. And so thank you for your stories. Thanks for listening. And I will see you on the next episode of the Rural American Surgeon.